Hello. So in the previous lecture, we have seen about the general approach to vertigo, how to approach a patient with vertigo. In this session, we will cover the other topics related to vertigo, the individual diseases or types of vertigo. Okay. So first one is acute prolonged vertigo. It is vestibular neuritis. An acute unilateral vestibular lesion causes constant vertigo. Okay. So in case of acute unilateral vestibular lesions, the vertigo is constant. Nausea, vomiting, oscillopsia, that is motion of the visual sphere, and imbalance will be seen. Symptoms are due to sudden asymmetry of inputs from the two labyrinth or in their central connections, stimulating a continuous rotation of the head. So this is why these symptoms occurs due to asymmetry of the inputs from the two labyrinths. So this is in the case of acute unilateral vestibular lesions. And in a patient presenting with an acute vestibular syndrome, the most important question is whether the lesion is central or brainstem infarct, that is the central, that is the cerebellar or brainstem infarct or hemorrhage, which may be life threatening, or peripheral, affecting the vestibular nerve or labyrinth, that is vestibular neuritis. So if a patient present with continuous vertigo and you suspect acute vestibular syndrome, then the most important part is to rule out whether the lesion is central, that is associated with infarct or hemorrhage, or is it peripheral, that is affecting the vestibular nerve or labyrinth in case of vestibular neuritis. Now, if the head impulse stress is normal, an acute peripheral vestibular lesion is unlikely. So, if head impulse stress, as we have seen in the previous lecture, if it comes normal, then acute peripheral vestibular lesion is unlikely. Now, most patients recover spontaneously, although chronic dizziness, motion sensitivity, and disequilibrium may persist for longer time. The role of early glucocorticoid therapy is uncertain. Antiviral medications, no proven benefit, and not given unless there is evidence to suggest herpes zoster oticus, that is Ramsay-Hunt syndrome. Vestibular suppressants medications may reduce the acute symptoms. Patients should be encouraged to resume a normal level of activity as soon as possible, and directed vestibular rehabilitation therapy may accelerate the improvement. Next is benign paroxysmal positional vertigo, BPPV, which is a very important one, and very often we encounter these patients in neuro-OPD also. So BPPV is a common cause of recurrent vertigo. Episodes are brief, that is less than 1 minute, and typically only for 15 to 20 seconds, and are always provoked by changes in the position of the head related to gravity, such as in lying down, rising from a supine position, and extending the head to look upwards. So what are the important features of BPPV? Recurrent vertigo, very brief episodes less than 1 minute or typically 15 to 20 seconds, and are always provoked by change in the head position. Rolling over in bed is a common trigger that may help to distinguish BPPV from orthostatic hypotension. So you will find this history very commonly, that while rolling over in the bed is trigger of sudden vertigo episode, and which lasts for very less time, that is less than a minute. The attacks are caused by free floating autoconia, that is calcium carbonate crystals that have been dislodged from the auricular macula and have moved into one of the semicircular canals, usually the posterior canal. And when head position changes, the gravity causes the autoconia to move within the canal, and these produce vertigo and nystagmus. So because of the movement of these autoconias, vertigo takes place. With posterior canal BPPV, now there are different types. With posterior canal BPPV, the nystagmus beats upwards and torsionally. The upper poles of the eyes beat towards the affected lower ear. Torsional nystagmus means the upper poles of the eyes beat towards the affected lower ears. Less commonly, the autoconia enter the horizontal canal, resulting in a horizontal nystagmus when the patient is lying with either ear down. Superior, or also called as the anterior canal involvement, is very rare. BPPV is treated with repositioning maneuvers that use gravity to remove the autoconia from the semicircular canals. For posterior canal BPPV, the Apley maneuver. So Apley maneuver is for posterior canal BPPV, is most commonly used procedure. This is how Apley's maneuver is done. It's used for treating paroxysmal vertigo of the posterior or anterior canals. Now there are these steps, 6 steps. First is begin in upright sitting posture, legs extended, head rotated 45 degree towards the side of positive deluxe spike test. Then patient is quickly passively forced down backwards into the supine position, head held approximately 30 degree neck extension. Third is observe patient's eyes for primary stage nystagmus, and patient remains in this position for 1 to 2 minutes. Fourth is patient's head rotated 90 degrees to opposite direction, and patient remains in this position for 1 to 2 minutes, and then patient rolls into shoulder, rotating head 90 degree. Patient now looking downward at 45-degree angle. Observe for secondary stage nystagmus and remain in this position again for 1 to 2 minutes. And the sixth step is patient slowly brought upright, maintaining 45-degree rotation of the head, and patient holds sitting position for 30 seconds. So these are the 6 steps of Epley's maneuver, which is done to treat this posterior canal BPPV. Now next is vestibular migraine. It is uncommon yet underdiagnosed because of episodic vertigo. Vertigo sometimes precedes a typical migraine headache, but more often occurs without headache or with only a mild headache. Some patients who have had frequent migraine headaches in the past present later in life with vestibular migraine as the predominant problem. In vestibular migraine, the duration of vertigo may be from minutes to hours, and some migraines also experience more prolonged periods of disequilibrium, that is lasting from days to weeks. And motion sensitivity and sensitivity to visual motions are common. So even in the absence of headache, other migraine features may be present. It's not necessary that headache is always there, but again the other features of migraines may be present, like photophobia, phonophobia, or visual auras, and these are typically treated with medications that are used for prophylaxis of migraine headaches. Next is Meniere's disease. Attacks of Meniere disease consist of vertigo, hearing loss, pain, pressure, and fullness on the affected ear. Low frequency hearing loss and oral symptoms are the key features that distinguish Meniere from other peripheral vestibulopathies and from vestibular migraines. So low frequency hearing loss is seen in Meniere's disease. Now audiometry at the time of attack shows asymmetric low frequency hearing loss. Hearing commonly improves between the attacks, although permanent hearing loss may eventually occur. In Meniere disease associated with excess of endolymph fluid in the inner ear, hence the term endolymphatic hydrops. Diuretics and sodium restrictions are typically the initial treatment. If attack persists, then injection of glucocorticoids, gentamicin into the middle ear may be considered. Non-ablative surgical options include decompression and shunting of the endolymphatic sac, and full ablative procedures like vestibular nerve section or labyrinthectomy are rarely required. Next is vestibular schwannoma. What are vestibular schwannomas? Vestibular schwannomas, also known as acoustic neuromas, and other tumors at the CP cerebellopontine angle, cause slowly progressive unilateral sensory neural hearing loss and vestibular hypofunction, and typically do not have vertigo because the gradual vestibular deficit is compensated centrally as it develops. The vestibular examination will show deficient response to the head impulse test when the head is rotated towards the affected side, but nystagmus will not be prominent. And patients with unexplained unilateral sensorineural hearing loss or vestibular hypofunction require MRI of internal auditory canals to look for schwannoma. So if a patient presents with unexplained unilateral SNHL or vestibular hypofunction, then MRI should be done of internal auditory canals to look for schwannomas. Next is bilateral vestibular hypofunction. Patients with bilateral loss of vestibular function also typically do not have vertigo because vestibular function is lost on both sides simultaneously and there is no asymmetry of the vestibular output. Vertigo commonly occurs because of the asymmetry of the vestibular output. So in case of bilateral loss of vestibular function, vertigo rarely happens. And symptoms include loss of balance, particularly in the dark where vestibular input is the most critical part, and oscillopsia during head movements such as while walking or riding in a car. Now, bilateral vestibular hypofunctions, these may be idiopathic and progressive, part of a neurodegenerative disorder, or iatrogenic due to medication toxicity, most commonly gentamicin and aminoglycoside antibiotics. The examination finding is diminished dynamic visual acuity due to loss of vestibular vision when the head is moving, abnormal head impulse response in both directions, and a rhombus sign. And response to caloric testing are reduced. Patients with bilateral vestibular hypofunction should be referred for vestibular rehabilitation therapies, and vestibular suppressant medication should not be used in these cases as they will increase the imbalance. Next are central vestibular disorders. The central lesions causing vertigo typically involve vestibular pathways in the brainstem or in the cerebellum. Lesions may be from ischemic or hemorrhagic stroke, demyelination, tumors, or neurodegenerative conditions that include vestibular cerebellum. Subacute cerebellar degeneration may be due to immune or paraneoplastic processes. Acute central vertigo is a medical emergency due to possibility of life-threatening stroke or hemorrhage. And all patients with suspected central vestibular disorders should undergo brain MRI, and the patient should be referred for full neurological evaluation. Other one is psychosomatic and functional dizziness. Psychosocial factors play an important role in chronic dizziness. If a patient presents with chronic dizziness, then you should definitely rule out psychological or functional. First, dizziness may be somatic manifestation of a psychiatric condition such as major depression, anxiety, or panic disorders. And secondly, patients may develop anxiety and autonomic symptoms as a consequence of comorbidity of an independent vestibular disorder. One particular form of this has been termed variously as phobic postural vertigo, psychophysiologic vertigo, or chronic subjective dizziness, but is now referred to as PPPD, that is persistent postural perceptual dizziness. What is this? PPPD, persistent postural perceptual dizziness. These patients have a chronic feeling. Duration should be more than 3 months or longer of fluctuating dizziness and disequilibrium that is present at rest but worst while standing. There is increased sensitivity to self-motion and visual motion, and a particular intensification of symptoms when moving through complex visual environments such as supermarkets. And treatment approaches for this includes pharmacological therapy with SSRIs, cognitive behavioral psychotherapy, and vestibular rehabilitation. And vestibular suppression medications generally should be avoided in such cases. What is the treatment of vertigo? Treatment of vertigo is medication should be reserved for short-term control of active vertigo only. They are less helpful for chronic dizziness and, as previously stated, may hinder the central compensation. An exception is that benzodiazepines may attenuate psychosomatic dizziness and the associated anxiety, although SSRIs are generally preferable in such patients. Now, various drugs and their doses: antihistamines like meclizine and dimenhydrinate and promethazines, benzodiazepines, diazepams and clonazepam, anticholinergic drugs like scopolamine, physical therapy, repositioning maneuver and vestibular rehabilitation, as we have seen about Epley's maneuver, and other like diuretic, low sodium diet, and anti-migraine drugs or SSRIs. Vestibular rehabilitation therapy promotes central adaptation process that compensate for vestibular loss and also may help habituate motion sensitivity and other symptoms of psychosomatic dizziness. The general approach is to use a graded series of exercises that progressively challenge gaze stabilization and balance. So this was all about vertigo. Soon we will be there with another lecture, another topic related to neurology. Thank you very much.